So as I said, the other day I just took lots of pictures of my cases. So um, first one was LSTG in the rectum, benign, good lift. Not, I would say probably not the most challenging case. So gaining access to submucosal space, we did a full assessment. You know, assess the risk, plan the approach. Mostly in the rectum, with very few exceptions, we're doing on block. So a lot of it does come for ESD. And then you want to start away from the lesion. And I'm not as good as this as I should be, but you want to start probably at 10 millimeters away from the start of your lesion. And there are some reasons for that. It allows you to approach the submucosal space at a slight angle. And as you go deeper and deeper, you're eventually underneath the lesion when you reach the interface between the muscle layer and SM3 level. It also makes it a little bit easier to get the cap underneath normal mucosa as against trying to get your cap underneath a lesion. Because as soon as you make a cut, the muscle retracts. Marking the lesion we've discussed earlier in the course, and I think when you're starting off, marking the lesion is a very good thing to do. And then you need to assess the topography and where the muscle layer is. So practice and rehearse your incisional movement. Tap, observe, repeat. Tap, observe, repeat. So this is what I was talking about earlier about thinking about how you're going to make a cut. So if you look at this, the knife direction here, so we're moving, so the muscle layer is here in this plane, yeah? And we're moving away from the muscle layer. If you're going in this direction, you're moving towards the muscle layer and you're going to be deeper. So if you're moving in this direction, you need to use that technique, which we demonstrated yesterday, where you go in with the knife and lift up, go in the knife, lift up, lift up, lift up, lift up. If you do this one, it's a little bit more efficient because you're dragging the mucosa and you're lifting it as you go. But as you're moving in this direction, you've either got to retract the knife as you come, or you've got to start pulling the scope away. And what you want to do is you want to maintain the knife and the submucosal depth the same throughout the whole cut. So you don't want to start deep and then go superficial, or start superficial and go deep. It needs to be nice and easy. And at all times, you'll be mindful of where the muscle plane is likely to be. And I would encourage you, certainly when you're starting doing the initial cut, having a good lift is a real safety margin. Now, when you're doing trimming, this is what I mean by being away from the lesion, because you're going to start your trim just underneath this cut edge. And this cut edge has got the lesion on top of it. The reason being is you don't quite know where the muscle layer is. It's in there somewhere, but we're not quite sure why. And freeing this top area will allow the mucosa to retract and should eventually expose the interface and the submucosal layer with the muscle layer underneath it. If you start going down deep into the submucosal space here, you run the risk of pranging the muscle before you've exposed the submucosal space fully. So trimming really means putting your knife just beneath this cut surface on the lesion side, okay? And we just let things go. It's probably worth thinking about gravity and the lesion. So gravity is going off to the right-hand side here. So access along this side is going to be a lot easier than access around this side. And once you start to gain access to a plane, it's usually fairly easy then to extend that across into the more difficult area to access. And this is what I mean. You want to get so we've made a cut, and then what we've done is we've put the cap in, and the cap's stretching the mucosa, and you've got a muscle layer here, and you've got the submucosal space here. Yeah? And ideally, you want this part of your cap underneath this mucosa. And at the moment, it's a bit too tight. But like what we've just seen with the palm, you've got to make the space big enough to be able to get the cap in. So this is it in sequence. We make a cut, we come along, we do a bit of trimming, and you can see we trim, it retracts. And what I've done here is I've gone for a circumferential incision. Didn't need to tunnel, it wasn't too big. As you can see, I've done a lot more trimming on the front edge than I have on the back because we're going to put some traction at the front. So this has all been trimmed from here to here, but you can see how it just gets pulled. This is your line of cut in the submucosa. You want to be sitting in SM3. So you want to be just above the muscle there. I think when you're starting, you can give yourself a little margin of error. In the right colon, the muscle is really thin, so we tend to give ourselves a little margin of error. But the whole point of doing an en-bloc resection is that you get an en-bloc pathological specimen. And if they're going to look at this, they need to look at all three SM layers. It's normally divided into SM1, SM2, SM3. Anything beyond SM1 is deemed invasion and it's probably incomplete. The trouble is you destroy SM3 with your knife, so all you're left with is SM1 plus a little bit of SM2, and that's what your pathologist is looking at. The higher you go, the less submucosa the pathologist got to look at, and then you run the risk that if there's malignant change, the malignant change can appear in the vasculature in the SM3 level, which you'll have missed if you go too high. So this is your line, okay? And as I say, you systematically work to expand the space and you look at where it's tethered. And if it's tethered, you want to release it. You want to release it. And you have to remember to work the edges. So we make a cut, and then you reach this stage, probably done as much trimming as I need to do, start away from the lesion, work through the space. And then I'm thinking, well, I could probably manage to do this without any traction. I probably could, and it would be a bit of a struggle. But what I found is that if you apply traction, it makes it very, very easy. So you decide in your submucosal space whether you're going to do a flap submucosal or a tunnel, and then you use gravity and traction and the cap to help expand the space. And just remember, if the space doesn't appear too big, the things you can do to expand the space are put the cap and wedge the cap in so it splints the muscle there and the mucosa, to inject into that space, which is a routine technique we use, but also deflate the bowel around it, because as you expand the intraluminal space, it stretches and it flattens the submucosal space. So what you want to do is you want to have relatively little air in the submucosal space, in the luminal space, to help expand the submucosa. As I say, it retracts, and you want to think of an access point. So you want to think of where the muscle layer is, where you've made your cut, where you're going to gain access the easiest, and then you want to apply your traction there to open up that space. So here, we're going to put some traction here, and you can see in the previous thing, we kind of gone as far as we could go. Yeah, we could dig the cap under here and we could keep trimming. It's so much easier just to put a clip on, put the clip on the opposite wall, and then you're fully exposed. You can see the muscle there beautifully. And if I was to attack this now, the black bits are where we've sealed vessels. You need to release this fiber. Then you probably need to release these fibers, and then just take this down and work your way in until you reach the same point all the way across. Okay, same here. We've used CO2 here, and then I put it underwater just to show you the difference. Okay, so get used to using saline immersion, because on occasion you will have to look at it like this. Could probably got a clearer picture than that. People who tend to do EMR and use CO2 tend to prefer this view because they think it's clearer. The problem is that patients can become vagal. Underwater magnifies. It also reduces the smoke when you're cutting. And if you're on the right side and you've got fat in the submucosa, it limits how much damage that causes to your lens. It doesn't cause damage, but it causes sustaining, and you get poor views. There is a heat sink effect from having the saline around. And what I mean by that is your thermal energy dissipates into the saline before it starts doing the cutting. So there's a slight delay compared with CO2.
Hey, John, can we come in? There is one question from the seminar room.
Yeah, fire away.
Yeah, so I wanted to ask you what are your settings, electrocoagulation settings for ESD, and especially, considering that you are using underwater in that situation.
And do you change them for air and underwater?
So I use Endocut I. So I've got an old Vio, so I haven't got the new Vio 3. So I use Endocut I, and I use swift coagulation. So it's slightly different to what you guys are using because you've got the new Vio 3. Are you using Endocut I or are you using dry cut?
We are dry cut or Endocut Q. So for the ESD, for the mucosal incision, we're doing dry cut. And for example, now in the poem that was undercut Q, but in
Okay.
ESD we use dry cut.
And you're
Yeah,
using
thank you, Joe.
and precise sect for the dissection.
If the plane is very tight, precise sect. If the plane is quite open, spray coagulation for the added effect of less bleeding.
Less bleeding, yeah.
Less bleeding.
So we haven't got that option, unfortunately. We talked about this vessel. So I leave the settings as they are, and I just wait for the delay. I don't change because I've gone into saline, so I don't change my settings. But I've got relatively old settings because I've got an old machine, and you get used to it. We talked yesterday about trying to identify the vessels, and what we do is we isolate vessels. So when you see a vessel, try and free the submucosa around it and leave it on its own, and that allows you to apply some coagulation. Either I use a 110 setting for forced coagulation. There are other options. You can use soft coag, or you can use a hemostatic device such as hemostat or the coag grasper before you cut through. It doesn't, you can't always predict it. And here we've had a bleed. I just wanted to show you this. And you can see how the vessels come through the muscle. They grow up through the muscle and they split the muscle. And then when you're sealing them and coagulating them, you run the risk of damaging the muscle underneath. So prevention is always better than cure, and cure runs the risk of causing muscle damage. So part of your learning curve is try to keep a dry field at all times. And then it looks really nice. Just becomes really easy to chop that off. So that took me 38 minutes to do that. So the timestamps are on the screen. You can become efficient once you understand these things. Second one was much more difficult. It was a tertiary referral with a lesion sitting on the medial aspect of the splenic flexure. And I've shown you this because you can look at the image of you, right? This guy was quite a big unit, and there's a lot of bowing. So there's a sigmoid loop, there's a lot of lateral bowing, and then you've got respiratory artifact at the flexure itself. And then they had said that there's central tethering, and they were worried about underlying possible submucosal invasion. And I had to put the patient in two different positions really to access the polyp. And the fact that I've took these pictures for you and I haven't got one picture of the whole polyp in view tells you the access is really difficult. So if you're dealing with tertiary referral work and this is the best picture they've got of the lesion, it means the access is really difficult. It's almost impossible to get a nice picture of the whole lesion. But we did manage to get a lift in. So we got the lift in the front is dead easy, but lift in the back is really difficult. So we start at the back. And we do a circumferential incision right around the back, and this came right up the fold and then over the top of the fold. And with this one, we used traction much earlier because it was just, once you'd done the circumferential incision, it was just easier to access the plane. It's less clear here, so as you move around to the right colon, you tend to get fat in this submucosal space, and it's less evident. But again, you can look at the topography of the muscle. You can see the muscle there. You can see the submucosal there. You can see where you need to get in with your cap. And then we use some traction here to lift it up. And we start at this edge. So what you do is the other principle about traction is, so firstly, you should try and grab the mucosal layer, not the lesion. Okay. And secondly, please don't pick up the muscle. Otherwise, you've got to take the clip off, or you end up with a perforation when you dissect underneath. And this actually worked really well, except for this back corner was really awkward. And we ended up firstly finding a huge vascular plexus here. And I wanted to show you this because despite my best efforts, we have bleeding from this point here. And this was one of a sheath of vessels in this area here. We pre-coagulated. This is using the hemostat forceps, which is a bipolar device from Pentax, which is a really nice device. And despite my best efforts, they were still oozing and bleeding, and you can already see. So firstly, there's some charring from the hemosiderin, and the reason it's yellow is because there's fat in the submucosa. And then the blackness is where you get hemosiderin staining within the tissue. And when you have an area like this, you worry about the fact that could this be an area of change because it's obviously drawing a vascular supply, or is it a big nodule? We eventually managed to control the bleeding, and then we put a second tether on. But the stability here was terrible. You know, you're not really got one-to-one. Controlling the tip is difficult, and at the same time you've got the lungs going up and down. So every time you make a cut, they breathe, you wait, you make a cut, they breathe, you wait, you make a cut, they breathe, you wait. Not easy. And then we eventually took it off, and you can see here, this is the area that was very vascular and bleeding, and you look at the rest of it, beautifully in, you know, white, nice muscle, and you've got all this hemosiderin staining at the bottom where you've had a bleed into the space. And you really want to avoid this because it's very difficult to define the planes once you get bleeding. So, you know, as you learn to try and not have bleeding because it just makes life difficult. And then this was the lesion. And this was the big nodular bit with the vascular bit underneath, but it looks benign. And then the final one that, well, there was an upper GI one, but we had the final one that morning was an LST non-granular lesion sitting over the rectosigmoid junction, and it had a truss. The truss had deemed it was T0 or T1 at the most, but couldn't really get to the lesion and said it was, the words were, it was fairly solid. So LSTNG over a fold, probably went for a tunnel. So again, similarly, although I'm doing a tunnel, I still do a circumferential incision because again, getting around the back of this is going to be really awkward. So you can see we've negotiated the scope, put the patient, can't see what position that is, possibly prone, but maybe not, and then inject the back, and we start at the back. Make the incision at the back, and you can see this coming round, and then we made a tunnel. And then the final one that, well, there was an upper GI one, but we had the final one that morning was an LST non-granular lesion sitting over the rectosigmoid junction, and it had a truss. The truss had deemed it was T0 or T1 at the most, but couldn't really get to the lesion and said it was, the words were, it was fairly solid. So LSTNG over a fold, probably went for a tunnel. So again, similarly, although I'm doing a tunnel, I still do a circumferential incision because again, getting around the back of this is going to be really awkward. So you can see we've negotiated the scope, put the patient, can't see what position that is, possibly prone, but maybe not, and then inject the back, and we start at the back. Make the incision at the back, and you can see this coming round, and then we made a tunnel. So cut right around the back, then started making a tunnel at the front. And once you get into a tunnel, it's really nice. You get this picture. Patients in my department are just under sedation, and what you find is if you do it under saline, you put less air and they get less vagal, and you get this nice picture. And you can, you have to orientate. You have to learn to cut. That you're not always going to be cutting horizontal at 6 o'clock. We're cutting through here, that angle there between sort of 11 o'clock and 5 o'clock. There's a little vessel coming out here, but importantly, you can clearly see the muscle there and the submucosal space, and the tunnel's nice for that. So just get used to cutting in various spaces. So we made this big tunnel here, and then we took down the right side. And I said to you, you know, taking down sides is not always that easy. And you'll see the patient flips position. So we take the right side off, that's fine. The left side, much more awkward to get at. So we change the patient position, and we put a clip on, and then we take it off. And again, you see lots of fat in the submucosal space. And this just makes your life very difficult, gets very smoky. You get lens opacification, and you have to take the scope out and clean the lens. But it comes off and everything's fine. Really. So the points being from here, you need a different approach for different lesions. Different lesions have different challenges, but the techniques are similar. So I'm a great believer now in having a circumferential incision. I know they talked about tunnels before. We did a tunnel for this, but I still did a circumferential incision. And even the Japanese now are making their tunnels, rather than a small incision at the front and a small incision at the back, they tend to make an incision at the front, which is wider than the lesion, and then they tunnel in. And as you tunnel in, you naturally come in. So your exit is usually a smaller size than the entry. It's just easier. The front retracts, which is why we used to make small incisions. So sometimes it's a little bit more difficult to get in the submucosal space. But as you get better at doing that, that becomes easier. And for Western practice, it's even easier if you put a clip and you tether it, and you literally put the tether in the anal side, and that keeps the hood over the top of your scope and allows you to tunnel far more effectively.